A continuación, cómo tratar la enfermedad pulmonar intersticial en enfermedad de tejido conectivo a cargo de la doctora Janet Pope. La doctora es profesora de medicina en la división de reumatología en la Universidad de Western Ontario. Es la jefa de división de reumatología en el Centro de Salud San Joseph y tiene títulos de medicina interna, reumatología y maestría en salud pública en la Universidad de Boston. Y tiene un especial interés en esclerodermia, lo que la hizo miembro fundador del Grupo Canadiense de Investigación. Thank you for invitation. Doctora Pope.
Great. Thank you, everybody, for attending this great session. We've heard about inflammatory myositis, GPA, eGPA with multiple lung involvements, including rare pulmonary vasculitis. We've heard about some of the imaging. And now we're going to talk a little bit about treatment. And I'm going to try to give you some clinical pearls as I go. So I would like you to be more familiar with interstitial lung disease and the connective tissue diseases. Try to determine who requires treatment, but we actually don't have an answer for that. And to recommend specific treatment, and I think in addition to have co-management with your respirologist or pulmonologist, the radiologist, the patient, and you. So the connective tissue diseases, I'm going to talk briefly about rheumatoid arthritis, and then the rest about the connective tissue diseases. And I'm going to give you some clinical pearls along the way. So we're first going to have a vote. So in which connective tissue disease is interstitial lung disease most frequent? So if you have the person with this disease, the people, what proportion of them would have the most connective tissue disease? So who says LES, lupus, systemic lupus? Who says Sjogren's? We just heard about some Sjogren's imaging. Who says inflammatory myositis? We heard about that. Who says systemic sclerosis? Yep. And who says rheumatoid arthritis, right? It's not a trick question. So rheumatoid arthritis is quite common. So it's about 1% of the population, about that in Colombia, even a little bit higher in Canada as our population ages. But only about 7% of rheumatoid arthritis patients have ILD that's clinically relevant, whereas in systemic sclerosis, you all voted correctly for those who voted. Now, this is from the literature, but I decided to add another column and just kind of make it up here. So I made up the final column on what I think is the proportion of clinically relevant interstitial lung disease. So first of all, there is interstitial lung disease that's more common in these diseases than what I'm telling you. But if we did a HRCT scan of going downtown today, we would find HRCT changes in maybe 0.5% of people, maybe even up to 1% of people. So if we do very detailed imaging, we'll find a little bit of bibasilar inflammatory or non-inflammatory fibrotic changes in regular people, mostly smokers, by the way, maybe post-pneumonia, things like that. So again, you voted right that the most common sequelae of scleroderma for interstitial lung disease is more common in scleroderma than in the other CTDs. Okay, so no surprise, but in connective tissue diseases, including also rheumatoid arthritis, having a major organ involved that we need to get oxygen to the rest of our body, if it's involved, it increases mortality. Not in everyone, but on average. Just like cardiac involvement increases mortality in connective tissue diseases, so does interstitial lung disease. No surprise. So this is a nice study from a couple years ago looking at a large clinic in Scandinavia following patients for about 4.5 years who did not have any major connective tissue disease, ILD, and interstitial lung disease at the beginning, and following them over time. And there's a couple take-home messages. Some people got ILD, that interstitial lung disease that was clinically relevant. Many people did not get it or did not progress. And about 25% over 4.5 years progressed pulmonary fibrosis, or interstitial lung disease. So not everyone will progress. Different rates of progression. These were mostly systemic sclerosis, inflammatory myositis, and mixed connective tissue disease patients. And the myositis were MDA5 mostly, and we heard about that already today. So our next clinical pearl, this is true for all interstitial lung disease in rheumatology. Treat the underlying disease. Reduce disease activity, and you might decrease lung progression. You might not, because the biggest risk of progression is having bad lung disease already progressing, but we need to treat the IA, inflammatory arthritis, the features of connective tissue disease, etc. So don't forget about the other organs so that we won't get more progression or we can reduce it over time. So another clinical pearl is we have varying amounts, you heard about that today in the myositis lecture, we have varying amounts of use of glucocorticoids. So as of, for instance, I almost never use prednisone in systemic sclerosis associated interstitial lung disease. If I'm going to, I might use 1 milligram per kilogram up to 50 milligrams for 1 month. If the person has no improvement of dyspnea, get rid of it. Rapidly taper and get rid of it. If dyspnea, it's clinical, improves, you can use low dose longer term, like 10 milligrams. This is anecdotal. The literature would probably agree with this, but there's no randomized controlled trials in scleroderma for this issue. And again, if you're treating scleroderma, especially early, diffuse, RNA polymerase III positive, you want to make sure that you are monitoring blood pressure if you give glucocorticoids, especially high-dose prednisone. And rheumatoid arthritis, more of rheumatoid, as you heard in the imaging, is pulmonary fibrosis. Pulmonary fibrosis, when you have honeycombs and your alveoli are broken apart and they're scarring, will not respond to glucocorticoids. Inflammation around it might. So in rheumatoid lung, often our patients have bad RA, not always, so they might be on background low-dose glucocorticoids. I hardly ever give high-dose glucocorticoids. If I do, again, you're going to make sure you have dyspnea improvement, and if not, in a month, get rid of it, rapidly taper to their baseline, which is low dose or none. In the other connective tissue diseases where it's interstitial lung disease, I don't mean alveolar hemorrhage, I don't mean aspiration, shrinking lung I would treat with glucocorticoids, but if it's interstitial lung disease and the other connective tissue diseases, absolutely will I use glucocorticoids with background immune suppression as well. So that's just a pearl. So let's briefly talk about rheumatoid arthritis. So these are some of my patients, and then the Kaplan syndrome here with pulmonary nodules I borrowed from the internet. So we have a range of patients with rheumatoid arthritis, and about 7 or 8% will have clinically relevant interstitial lung disease. It's so fibrosis is mostly at the bases, and in all our patients with connective tissue disease and RA, we get more lung involvement on average in the bases, whereas if you have ankylosing spondylitis, it's more fibrosis at the apices. That's the only exception to the rule. The prognosis in rheumatoid lung, if they have honeycombing and fibrosis, is as bad as IPF, idiopathic pulmonary fibrosis. Interstitial lung disease, a little bit more common in men than women, more common in older age, more common in smokers, maybe more common in antibody positive, maybe not. And again, if you have interstitial lung disease, you're more apt to die. So rheumatoid arthritis associated ILD has a big drop in survival even early on compared to rheumatoid arthritis without ILD. So we're going to have a true or false, and you can vote. So we're going to vote true and then false. So true or false, methotrexate is associated with more chronic interstitial lung disease with rheumatoid arthritis. Who says yes, true? And who says false, no? Excellent. So we seem to know it. Sometimes our colleague pulmonologists don't know this, and so you know it. You know this story. So this is a systematic review of multiple cohorts and registries showing that methotrexate is protective against getting chronic interstitial lung disease. I don't mean methotrexate acute pneumonitis. Acute pneumonitis from methotrexate should not give you chronic interstitial lung disease. It's a different problem. The other thing, though, this is not a randomized controlled trial, so there would be channeling bias. If my patient has really bad lungs, maybe I wouldn't even start methotrexate. However, it's not all due to channeling bias. Treating the underlying disease will decrease incident and progression of interstitial lung disease to some degree. So you know that. So what do I do? So this is my opinion, somewhat literature-based and a lot based on my own personal opinion. So you can take it or leave it. But there's RA treatments that I think are lung-friendly. So we all think of rituximab, abatacept, tocilizumab, and you heard in the myositis lecture about JAK inhibitors. Likely not lung-friendly might be leflunomide and TNF inhibitors. I don't know if that's true, but there's two caveats. We would use leflunomide in the days way back when methotrexate was failing, so more difficult to treat patients. Also, TNF inhibitors at the initial prescriptions of them in the early 2000s were in our most severe patients. The other thing is the TNF inhibitors, it seems to be mostly Japanese literature that is finding this. So whether the likely not lung-friendly is true or not, I don't know. Glucocorticoids I put as a question mark, and then the antifibrotics where nintedanib has far more data in this area than pirfenidone, in my opinion, from the trials. Also, you want to treat the underlying disease, so that's why we talked about that. You might consider mycophenolate mofetil, cyclophosphamide, or azathioprine in addition to treating the underlying disease. Do I stop methotrexate if someone's interstitial lung disease and RA is progressing? What I can tell you is if their ILD is progressing, they've failed methotrexate, so maybe I'll add something to get disease activity in the lungs better, or maybe I'll switch. But I'm not switching because methotrexate's bad for your lungs. I'm switching because they failed if I switch. Okay, so these are, in brief, the trials. So the InBuild trial was looking at nintedanib, usual dosing versus placebo in interstitial lung disease, the progressing pulmonary fibrosing phenotype, including rheumatoid arthritis. And you can see in all the subsets, it is favoring less worsening, so it's favoring nintedanib over placebo. What about looking at systemic sclerosis? So again, many of my patients, many faces and hands of systemic sclerosis, and many different lungs in systemic sclerosis. Not everyone will progress. So the first thing, in early disease, your mortality in systemic sclerosis is based on worsening forced vital capacity. Early interstitial lung disease, higher mortality. It's also based early on worsening skin score. Rapid progression, higher skin score is more apt to kill you. And later disease, your skin score might have regressed, and so it's not as related to mortality what the skin score is at 5 or 10 years as early disease. So the lungs and skin are very predictive. So this is a study we did looking at incident cases of scleroderma, systemic sclerosis, in the population of our province. So Ontario is the same population as, say, Sweden. So a large database where we looked at scleroderma patients, and we found that if you have interstitial lung disease, even in year 1, you have increased mortality compared to overall systemic sclerosis. We also found, unfortunately, that there is a downhill survival in scleroderma, whether you have ILD or not. But you can see you're doubling the death rate by 5 and 10 years if you have interstitial lung disease. ILD is not good for you in scleroderma. 15% of patients had this finding of progressing ILD, killing them, and that is about giving face validity to how we sort of found this on a great big administrative database. So these aren't people coming to my clinic, as a for instance. These are people in the province getting medical attention. So we have a treatment algorithm. You saw this yesterday as well from one of the other presenters. So I just added the blue on there of where to put the antifibrotics. But a couple clinical pearls, so we're kind of avoiding glucocorticoids. Most experts would not bother with prednisone. The next clinical pearl is mycophenolate mofetil has surpassed cyclophosphamide for the first-line treatment in scleroderma lung disease. Then it's anything goes. We probably would find in Colombia more rituximab. In the US, maybe more tocilizumab. In Canada, second-line treatment would be cyclophosphamide or rituximab. So it depends on access. And I think that this is important to note that we have the proven therapies. If ILD is worsening, whether it's progressive fibrotic phenotype or not, if your interstitial lung disease on treatment is worsening, I've ruled out infection, aspiration, things like that, then I might actually consider the antifibrotic treatments as well. If it's worsening and there is fibrosis, for sure I'll consider it with co-management. So the next clinical pearl, I'm talking about treatment. Nobody agrees who should be treated with systemic sclerosis. Really severe, easy, antifibrotic, maybe immune suppressive. No interstitial lung disease, easy. We're not going to treat the ILD. There's a lot of people in between with no consensus. So I'm talking about treatment, but you got to realize we don't know who to treat sometimes. So there might be a window of opportunity in early systemic sclerosis. If you intervene with mycophenolate mofetil, you might get better pulmonary functions, less new interstitial lung disease, and even if you intervene with other immune suppressives, such as methotrexate, this could be the case. So there could be a window of opportunity, especially early diffuse patients, in preventing or reducing the onset of interstitial lung disease. Could be. So does treatment of mild interstitial lung disease with immune suppression improve lung function? Yes, no, maybe so. So the yes is our Canadian Scleroderma Research Group. We looked at this, and there was definitely a trend that if scleroderma patients, early diffuse, received mycophenolate mofetil, they had less new interstitial lung disease, less worsening. So that's the yes. There might be a window of opportunity. Here's the no, though. This is underpowered, but it is a randomized controlled trial. So this was looking at mycophenolate mofetil versus placebo, double-blind, randomized study, but only about 20 people per arm, seeing if mycophenolate mofetil would reduce having lung function changes over the time they were followed. So they had to have a forced vital capacity greater than 70% predicted. So the bottom line was there was no difference, but they weren't followed for a long time, and it was underpowered. So I think there's a window of opportunity, but not all data will show it. Okay, so we do have treatment. So you heard yesterday, if you went to one of the symposium, about the interstitial lung disease and progressive pulmonary fibrosing phenotype. And in this group of patients, our goal of treatment is to lower the slope of worsening. We don't want you worsening like that, like this. We'd rather you worsen like this, or we want stability. In early disease or people without a lot of honeycombing or fibrosis, we want improvement. That's my opinion. Not everyone even knows what our goals of treatment are. Improvement, stabilization, less worsening, depends on the patient. And this showed less worsening very clearly in patients who received nintedanib than placebo. It also showed that if you were on mycophenolate mofetil plus nintedanib in a secondary analysis, exploratory, that you had the least amount of worsening, either nintedanib or mycophenolate mofetil, the next least amount of worsening, the most worsening if you were on placebo and no background immune suppression. So would I continue the immune suppression in these patients, such as MMF, mycophenolate mofetil? Yes. Okay. We also have heard a little bit about tocilizumab for interstitial lung disease. First of all, the tocilizumab trials were relatively early diffuse patients. They couldn't have severe lung disease, and it wasn't a lung trial. The vast majority did not have clinically relevant interstitial lung disease. So FDA approved this drug in prevention of progression of interstitial lung disease. And that is true, and I think the circle might help you best. The proportion of patients who had a decline in their forced vital capacity over only a year, 48 weeks, of 10% or more was about double if you were on placebo compared to if you were on tocilizumab, the red. So do I use tocilizumab? No, because I don't have access. Would I? probably if I had access. Tocilizumab wasn't great for skin. MMF is not great for skin. We'll hear more about that later today. Rituximab and interstitial lung disease, we've heard a lot about that. This was a systematic review, randomized controlled trials and case series. And look at the conclusion line. Treatment with rituximab in scleroderma ILD gave a significant improvement in forced vital capacity and the diffusing capacity. And you're aware of that from the recital trial. So in the recital trial, it was a randomized controlled trial looking at cyclophosphamide or rituximab, including systemic sclerosis, other CTDs, looking over only at 24 weeks, and rituximab had more improvement or less worsening. Intensive therapy in your really bad patients, rapidly progressive skin might indeed help their lungs, which makes sense. So early on, your skin might mirror what's going on in the lungs, not later. And this was showing significant stabilization or improvement in patients who were on cyclophosphamide and glucocorticoids and rituximab. So they were your sick patients. Should we screen for ILD and systemic sclerosis? Yes. Why should we screen? Because it's common, because it is somewhat treatable, and because we can prognosticate, and we do have lots of options for our patients. So can we predict who progresses? No. So the worst is that dotted red line, and most patients are not in that line. That's only 16 patients out of 330 some patients. So we can't predict. You can see some people improve, the green, yellow leveling, and this is what happens in the real world clinics. So we don't know who to treat if it's mild and they're already stable or improving on their own, or they're not very badly off. These are the risk factors: men more than women, higher skin scores, high inflammatory markers. You heard about that today already, of the C-reactive protein or the KL6. In the US, the African Americans have worse prognosis. In Colombia, your native peoples might have worse prognosis than someone who lives urban, non-native person, maybe. Who progresses? The only thing we could find in progression over 3 years in our Canadian Scleroderma Research Group, it wasn't people with SCL70, topoisomerase, although some studies have shown progression is increased in that group. Certainly bad ILD, getting ILD is increased in that group. But progression, the only factors we could find, inflammation markers, clinical factors, baseline PFTs, pulmonary function, was aspirating in your lungs. We have to make sure our patients aren't having severe GI involvement. If they are, we have to do the anti-reflux procedures, get them dilated and things like that, because that will make your lungs worse. So this is, I put it up because it's kind of a summary of what I've said to date, and I stole this from Dr. Chris Denton. Well, he lent it to me or gave it to me to use. So it's pretty detailed, but some people that want to study later can certainly look at this. So this is my idea of treatment, mycophenolate mofetil. If not, I would go and add rituximab or switch to cyclophosphamide, oral or intravenous. I have no access to tocilizumab right now. If it's progressing, I'd use the antifibrotic, mostly nintedanib, and getting lung transplantation. In Canada, they wait a long time on the wait list because organs are scarce, so that doesn't happen very often, but can. What about in the next 3 slides, like other connective tissue diseases? So you see my patient with systemic lupus erythematosus, LES, the middle one with Sjogren's, dry tongue, and dermatomyositis with the heliotrope. You can see mechanics hands, and you can see the changes in one of the other patient's hands. So the other connective tissue diseases, the recital trials showed that rituximab was better than cyclophosphamide over 24 weeks, with more improvement in the non-scleroderma patients. But the scleroderma patients, mostly had already failed or been exposed to mycophenolate mofetil. They were already on some treatment before they got in the study. So the pearl here, rituximab is preferred over cyclophosphamide in CTD-associated interstitial lung disease. We've talked about the antibodies. Not all myositis has the antibodies you think of for interstitial lung disease, such as JO1. There's a range of who gets interstitial lung disease, from rapidly progressive to very low risk, and many people in between. So the other diseases, treat the underlying disease, treat what's treatable. Maybe you'll use glucocorticoids and immune suppression, maybe cyclophosphamide, IVIG, mycophenolate mofetil, azathioprine. We heard about tacrolimus. We heard about triple therapy as well in myositis today. Lots of potential treatments. So treat what's treatable, treat the underlying disease. Cyclophosphamide is going down on its desire to be used. Rituximab is going up. Mycophenolate mofetil is our first-line advanced therapy in systemic sclerosis. And always think that you want help, you want co-management. We want, if we're not sure who to treat, we want other specialists to help us make that decision for the patient to get the best care. So with that, I thank you.